All of you saw what a cohort study is last time, right? Among all the observational designs, the cohort design is the strongest, okay? And a cohort design is essentially like a randomized controlled trial with one huge difference. That is, we do not randomize people to any exposure in a cohort study. We merely observe, document the exposures, and then we follow up to see what happens in terms of outcomes. Cohort studies are potentially powerful, but they do require a lot of investment in terms of time, in terms of measuring a large enough group of people and sticking with them to see how disease events pop up in a cohort over a long period of time. Long or short depends on the nature of the disease, but generally cohort studies require considerable investments. Now, in the 1950s and 60s, some people asked the question, is there any way we can logically condense this investment and find a way to get at what we would get without really putting in that kind of effort? And thus was born the case control design. It's actually a very powerful design if you understand it, okay? And it can give you almost the same information as a cohort study could give, right? But it's a big if because there are a lot of methodological challenges in pulling off a good case control study. But if you were to do a good one, then you could potentially get to wherever you would get in a well-done cohort study at a much cheaper price tag and much faster than you would ever do in a cohort study. So let me start off with giving you an example of a case control study from the COVID world, okay? Acute onset smell and taste disorders among patients with COVID, right? The question was, are smell and taste, loss of smell, loss of taste, much more frequent among COVID patients compared to people with other disease? So this is a easy question to answer if you set it up as a case control comparison. So case here was defined as consecutive patients in a hospital, in 2 hospitals with COVID PCR positive, right? COVID PCR positive patients were cases, quote unquote. Controls for this particular study was 40 patients positive for influenza, but not COVID, right? They don't have COVID, but they have some other viral infection, namely influenza. They could have chosen a different control group. They could have chosen other people hospitalized at the same time in the same area, but were PCR negative, right? They could have chosen a different control group. Then once they set up the case control comparison, then you asked, okay, do you have loss of smell or taste? When did it begin? Which, what was the time frame? What other symptoms do you have? So on and so forth. And the results turn out something like this from this study. They had a total of 79 cases. And you see here, that is how the case control study is always set up. The 2x2 table is case at the top, column 1, all the controls in column 2, and whatever you think is the exposure is on the horizontal axis on the rows, right? So there were 79 cases of COVID, of whom 31 had smell or taste disorders. Okay, so the odds of smell or taste disorder among COVID patients was 31 over 48. Odds, not probability, odds, right? Number of times an event can happen divided by its complement. Among the control patients with influenza, 5 out of 40, the odds are 5 out of 35, had smell and taste disorder. If you divide the odds of being exposed if you were a case, divided by odds of being exposed if you were a control, you get a ratio of 2 odds. Odds 1 divided by odds 2 gives you the ratio of 2 odds. That's why it's called an odds ratio. The odds ratio in this particular instance, if you do the math, is 4.5. You will get the exact same 4.5 if you did a cross product, AD divided by BC. 31 times 35 divided by 5 times 48 will also give you 4.5. Okay? Because it's a cross product, it's symmetric. It doesn't care in which direction you do it. Okay? So that AD over BC, also called a cross product, basically summarizes the association between COVID and smell and taste disorder. And if I were to explain this odds ratio in simple English, I would say patients with confirmed COVID disease were 4.5 times higher odds of having lost smell or taste compared to people with non-COVID disease, namely influenza, right? If you round it off, you had a 5-fold increase in smell and taste disorders if you had COVID compared to if you had no COVID, in this case, influenza, okay? Now, if you do a confidence interval around it, I predict it will be statistically significant. It will not overlap the null value of 1 because 4.5 is a very strong relationship, right? If this odds ratio was 1.5, then the relationship between smell disorders or taste disorder and COVID would be very weak, right? I think everybody now in the world accepts that COVID does cause smell and taste disorders. Not in everyone, but there's a very strong link between COVID and smell and taste disorder, which is what this study confirms. All right, that's an example of how a case controlled study is designed and analyzed, okay? Now we'll talk a little bit about how exactly case control study is different from a cohort study, okay? So the way we think about a cohort is this graphic I've shown you many times, okay? And it's worth emphasizing again how we think about a cohort. Cohort is a bunch of people with whom they don't have the disease at the start, and then we wait and see what on earth happens to them. If any of you have seen that movie, Truman Show, where this guy is observed through his entire life on everything he does. Imagine if all of us, the whole entire world's population, was observed over a period of time. All our exposures are documented. Do we smoke? We don't smoke. What do we eat? We exercise. We don't exercise. Everything is documented. And then our life events are documented, right? Do we get heart disease? Do we get a stroke? Do we have a road traffic accident? Everything is documented in our futures. If you could get that kind of a magical database, you'll know exactly what exposure causes what disease, right? So this is what we are trying to do in a cohort study. A bunch of people are recruited and we just stick with them over a period of time. Each person in the cohort is observed for a certain amount of time, either until they develop the disease, until they die of something else, they disappear from the population, they drop out, whatever it is, until censoring happens. We have a certain amount of person time observation we make on them. If you aggregate the entire group's person time together, you get the hatched area, which is the area under the curve. That is the total aggregate person time follow-up contributed by this particular cohort. In that sea of person time follow-up, the black dots show new disease events popping up. The new disease event could be COVID. The new disease event could be stroke. The new disease event could be new onset of cancer. Whatever the conditions are, they are popping up in this entire cohort that is moving forwards in time, right? Now, if we could get this, basically then what we would do is we will disaggregate the entire person time follow-up, the hatched area, into exposed person time versus unexposed person time, right? We strip apart this entire mass of person time into those who happen to be exposed compared to those who were not exposed. Now, the beauty of this design is that it doesn't pin anybody down to only one state. In my life, for example, I could have smoked for 2 years in my life. The remaining 40 years, I may not have smoked. So then what would happen to me is that I would appear in both the plots. 2 years of my time will be counted in the exposed person time category. 40 years of my life will get counted as the unexposed category. Except for things like sex or genes, very many things in life are things that change over time, right? I may not have been physically active last year, but I choose to be active now. My risk changes, right? So my physical activity, intense or not intense, will get categorized in different buckets. So that's the beauty of not having a fixed cohort, but a cohort that changes and where the exposure also changes over time, right? We get older. Our exposure in terms of age is different now than it was when we were children, right? So you can count exposure in many different ways. The beauty of it is whatever the total exposed person time, say for example, all the people, no matter how long they smoked, they get put into the exposed person time category in the denominator. In that group, you ask how many black dots appeared. Black dots are the number of new events. So among all the smoking person time that you could take out of this cohort, how many black dots appear? The density of black dots in the hatched area is the best way to think about an incidence density. That's why it's called incidence density. Think of the number of black dots in the total smoking person time exposed group. And I've shown you deliberately a larger number of black dots if that is, say, smoking and lung cancer. Among all the people who are smoking, you should see a higher number of black dots because that's where we expect lung cancer cases to happen. There are a few black dots in the non-smoking category as well, because not all cancer is because of smoking, right? Now, you take the incidence density, also called incidence rate, in the smoking person time group, divide it by the incidence density or incidence rate in the unexposed person time category, you get an incidence rate ratio, also called an incidence density ratio. This is what a good cohort study will give you. Then you take that incidence density, you adjust for confounding, you hope that is taking you as close to the causal truth as possible, right? An adjusted incidence density ratio in a well-done cohort study is as good as coming close to a true causal risk ratio for that particular association and outcome. This is the dream design, okay? Now, the painful aspect of this design is that you have to have sufficient number of people and you have to stick with them. You have to know exactly when they were smokers, when they were non-smokers, so that you can separate them out. So you have to measure exposures repeatedly, and then you have to wait for all the black dots to appear. You have to have a surveillance system to pick up every case of lung cancer or COVID or stroke that appears in a cohort, right? There must be a mechanism to see who developed disease and when they developed the disease. Then you'll be able to analyze the data, and the cohort design is inherently longitudinal, right? Cohort study is always longitudinal in terms of its movement into the future, okay? Excellent design, painful to do. Now, the case control design is essentially a way to trick the situation into giving us pretty much what we would get from a cohort study. Instead of doing this, waiting for the cohort to be follow-up to be complete, and then looking at the incidence density in the exposed versus unexposed, we ask the question, as the cohort is happening over time, if we could take a random sample of all the black dots, okay, a fair sample of all the new cases that are popping up in this cohort over time, right? Either all or at least a fair random sample of all the black dots. If we could get that, then we would get all the cases in the case control study. Essentially, in this sea of percentile, we want a fair sample of the black dots. Okay, if we could get that, then we could ask what proportion of the black dots, people with lung cancer, were smokers. Historically, we could ask them or use records to say, were you a smoker? When were you a smoker? How many packs of cigarettes a day? We could collect all that historical exposure information, right? Now, we then can get odds of smoking among the lung cancer patients. Okay, that's easy. Now, but what do we compare it against is where the crisis is. We need a fair sample of the non-cases, people who could have developed lung cancer, but did not for whatever reason at that time, right? That is a fair sample of the total study base is what we are looking for. Study base is anybody else in the cohort who could have developed lung cancer at that time, but for some reason did not, right? If we could get a fair sample of those people, and again, we ask the question, are you a smoker or not? When did you smoke? How many packs of cigarettes a day? Then we have the case-based comparison. We could call it a case-based study. We could call it a case reference study, or we could call it a case control study. The word case control is often used, but I have seen people call this a case referent design or a case-based design, right? We need a fair sample of the black dots. Then we ask about exposure. We need a fair sample of anybody else in the cohort at the same time who could have become a black dot but did not become a black dot. If we could get them into the study and we could document their historical exposures, we are done. Then what we would get is the ratio of two odds. And that odds ratio, if you did it like this, is pretty much identical to this painfully collected incidence density ratio that you would have gotten in a cohorts design, right? That's what makes a case control study a powerful way of collecting whatever you would have painfully gotten if you had done a cohort study longitudinally over months or years, right? It's less expensive, much faster, but it's easier said than done, right? This is a dream design to get your cases and your sample of your base, but in practice, it's much harder. And I will explain to you why it's so hard to do a well-designed case control study, right? But the critical thing about the case control study is that cases and controls must come from the same study base. The study base is that hatched area under the curve. Study base is the total aggregate person time in which all cases happen. Or alternatively, the cases and the controls must come from the same underlying source population. You cannot pick cases from here, controls from some other part of the world. If they don't come from the same source population, then it is an invalid case control study. Okay? Both cases and controls, think of it this way. A control could have been a case, right? A control could have been a case, but for some reason didn't become a case, right? That is what is important. Controls must be an unbiased sample of the study base or the population that generated the case. Whichever population threw up the black dots, control should be a sample of the same study base or the population, right? So there are situations when the study base or this underlying source population is crystal clear, right? Take a look at the study, risk factors for skin cancer, a nested case control study within the nurses health study. The nurses health study is a massive cohort study still happening among United States registered nurses. They enroll large number of nurses in America, and they've been following them up for decades, right? It's an already well-established cohort study of thousands and thousands of nurses in America, right? But then for this particular study, they did a case control study nested. Nested means buried inside a bigger cohort study, right? So that's why we call it a nested case control study. There was already a big cohort study going on, but they only did a smaller case control study within that cohort of nurses. In this case, the study base is clear. It's all the nurses who are currently being followed up in the nurses health study. But sometimes we are never sure what exactly is the underlying population from which cases and controls are coming up, right? For example, here is a case control study I was collaborating with Dr. Kalantri and others in Sevagram, okay? We looked at risk factors for acute myocardial infarction in a rural population in Maharashtra, okay? You see here, our title was a hospital-based case control study, right? So here's what they did. All consecutive patients with acute myocardial infarction admitted to the Mahatma Gandhi Institute in Sevagram between a certain time were included in the study. They were all cases. And there was a clear definition of what a myocardial infarction is. Cases are always easy, right? You go to any hospital, you will find cases. Cases are always easy to recruit. No matter what, you will find them, whichever place you went, right? So all acute myocardial infarction at Sevagram are the cases. Now comes the biggest challenge. What is the correct control group to compare them against, right? So we were scratching our heads on what is an appropriate control group, right? Now, to understand what an appropriate control group here would be, we need to then understand who shows up at the Mahatma Gandhi Institute, right? Is the Mahatma Gandhi Institute primarily serving a local catchment area of all the villages around Sevagram? Is that what the catchment area is? then the control should also reflect that catchment area from which people show up at the Mahatma Gandhi Institute, right? If we could define the community served by the hospital, and if you could get a fair sample of that community, that would be an acceptable control group, right? But sometimes it's very hard to say what on earth is really the catchment area. Let's ask, what is the catchment area for AIMS New Delhi? I have no idea. Is it people who live around the AIMS area? Is it people from all over India? Is it people from Bihar, UP who get on a train and land up at AIMS? It's a rag bag of all sorts of interesting, referral patterns. Sickest people land there. It would be a nightmare to really know what is the catchment area for AIMS. When I was working at CMC Vellore, we had patients literally get on a train in West Bengal and come 28 hours later to Vellore to seek care, right? So Vellore wasn't the only catchment area for CMC. CMC had a much bigger referral network. So sometimes it's very hard to know what the catchment area is and to get a fair sample of controls. But in this case, we chose age and sex match controls. Controls were recruited from patients admitted at the same time to the same hospital, but in surgical wards for minor surgery such as hernia repair, hydrocele, cataract, or those who are visiting the outpatient departments for minor ENT procedures or general health examination, right? So we ended up choosing hospital-based controls, people who were seen at the same hospital for other disorders such as minor surgery, ENT complaints, and so on and so forth. You could argue, was this really a fair control group, right? In other words, we had to kind of assume that these people who showed up at the same hospital for, say, hydrocele or hernia or cataract, if they had developed an MI, would have also ended up in the same hospital, right? That's a kind of a justification or thinking we had to make to even make that claim that this was a reasonable control group, right? So hospital controls are dicey. It depends on what the hospital catchment area is and whether people will end up at the same hospital if they had different diseases. In India, hospital-based controls are always dicey because we have this big, massive problem of affordability, right? Only people who can afford in private hospitals can even get there. So you're already ruling out a whole bunch of people in your underlying source population because they can never afford the care that they need to get. So all of this makes hospital controls a bit dodgy. Regardless, this is what we ended up doing in this particular study. The problem is not in as much as having a hospital control group. The problem is, did we do a proper job of justifying it? And did we do a proper job of discussing the limitations of our control group? That's what makes a good case control study different from a bad one. Are we even able to think through the consequences of an inappropriate control group, right? Now, here is a graphical illustration of how cases and controls are accumulated and analyzed. So here is an underlying hypothetical cohort. Each line is a human being going forwards in time. Black dot is when the disease happens, right? Each person is contributing varying levels of person time, which is the varying sizes of the lines. And then the black dots, say in this case, are 4 cases that appear in this particular cohort. So each of that black dot is a case. So you need to have a system where you should get either all cases in a cohort or a fair random sample of cases. You cannot cherry pick only some and others. You must have a fair sample of the cases. That's requirement. Then, at the same time, ideally, could you also find other people in the same cohort who could have become a black dot but didn't, right? They should be eligible to develop the disease and they could have developed the disease, but they somehow escaped, right? And if we could get a fair sample of the controls in the study, then if we could calculate the odds of being exposed if you are a case divided by odds of being exposed if you're a control, then you generate an odds ratio. And that odds ratio will methodologically approximate a risk ratio in a cohort study. Okay, That's the power that a well-done case control study gives you. Okay. Ideally, cases and control should be matched on time. Whenever a case pops up, a control should be selected at the same time among all others who could have developed a case at that point but didn't, right? The matching on time is very powerful if you can do it, and you can invariably do that in a nested case control study, right? Now, what are the types of controls? I already gave you one example of hospital controls, right? Both the COVID case study I gave you as well as the Sevagram one were hospital-based controls. So you can select controls from the community, also called population-based controls. You can select controls from hospitals. You can select controls from a medical practice, right? For example, there was a GP, and the GP has, all the GPs have their own medical practice. You can select controls from them. You can select friends of the case as a control, friend controls we call it, right? You can get the household members, right? Household controls, relative controls, friend controls, various approaches to control selections. And to be honest, every one of them has their advantage. Every one of them has a disadvantage. There is no perfect situation of how to select a control. The dream situation for a control is you already have an ongoing cohort study like a nurse's health study. You know everybody who's in the study, you know what the cohort is all about, and you can randomly select controls from all the nurses in the nurse's health study. That would be a dream situation, which rarely happens, right? But that would be the ideal if you can pull it off. Now I'll illustrate some of these dilemmas on the ideal control population when I talk about bias in case control studies. So the biggest bias in a case control study is the control population. Are you doing a good job of control selection? If you get a bad set of controls, methodologically bad set of controls, you can completely bias your study results. The fate of a case control study hinges extraordinarily on that critical variable. Did you get a fair control population? In other words, were your controls representative of the mother population from which cases arose? If the answer is no, then you probably have a huge selection bias in your study. Okay. And selection bias does happen in case control studies, which is why we never talk about case control studies without agonizing over what our control group was. Okay. So here is an example. This was done by my boss at Berkeley when he was working for the US CDC. In those days, I'm talking about the 1980s, there was a syndrome described called toxic shock syndrome, right? Women who used tampons, later on it became clear if the tampons were not hygienically done, they could soak up the blood, they could get infected, and that could lead to toxemia because of staphylococcal infection, right? The early days, that was not very, very clear. So they were trying to do case control studies to see who is likely to get this toxic shock syndrome, right? So cases where women between a certain time period in 6 study areas where they were diagnosed to have toxic shock syndrome, okay? That was easy, right? Toxic shock syndrome, women with toxic shock syndrome. Now, who is a control for this? Who do you compare that women against, right? So they took aged match controls and they picked 2 different types of controls. You could have more than one control group in a case control study. So in this case, the first control group was you ask the woman, give me a list of all your friends who are in a similar age bracket as you. And we all have friends in our own age category, right? It's highly unlikely that we'll have friends who are much, much younger or much, much older. So each woman said, okay, here are my 6 friends, my 3 friends, my 1 friend, right? And they randomly picked a age and sex matched friend from the list of friends that the cases gave. So we call this a friend control, right? And then they also said, give me your telephone exchange. Give me your area code, your PIN code. We'll find your telephone exchange. And then we take all the phone numbers in your telephone exchange and we'll make random digit dialing. And we'll find the first age matched woman we find and we invite her to be a control. So in some ways, the friend controls, and then there were a surrogate for a community control from the telephone exchange that where the women were residing in. Okay, so they had 111 case patients, of which 108 were enrolled, and there were 185 friend controls and 187 telephone exchange match controls. I would consider the telephone exchange match controls as some kind of a community control, right? It all depends on whether they have a phone or not, for sure. It also depends on whether their phone number is listed or not. It also depends on whether they answered the phone or not, right? There are all sorts of issues involved with telephone-based sampling, but regardless, that's what they ended up doing, okay? Now take a look at the results of what they found when they used this particular approach, right? The odds ratio when both type of control groups were combined was 29. In other words, women who used tampons had a 29-fold higher odds of developing toxic shock syndrome. Okay, so very powerful association. This and other case studies absolutely demonstrated the link between tampons and toxic shock syndrome. But look at the odds ratio when friend controls were used. From an overall odds ratio of 29, it dropped to 19. Still significant, very significant and strong, but it dropped considerably to 19. When we use the telephone exchange controls, the odds ratio jumped to almost 50. Very powerful association, right? 50 is a massive association between any exposure and outcome. So the question is, what happened? Why did the friend controls underestimate the odds ratio and push it towards the null value, right? Still significant, but nothing as powerful as 48, right? Turns out this is what happens. When you have a friend control, essentially your friends are like you. When you hang out with friends, if you're a smoker, is it possible that your friends are also smokers? The answer is yes. If you go out drinking in a bar, is it possible that your friends also drink? The answer is yes, right? And do you hang out with friends of a similar socioeconomic status? The answer is yes, right? We tend to hang out with people who are like us in many ways behaviorally, right? If I do drugs, it's highly unlikely that I'm hanging out with friends who also do drugs, right? Friend controls, and when you recruit friend controls, you run the risk of making the controls look very much like a case in every behavioral trait, right? Now you're making sure cases and controls are very similar to each other. So in this case, if the cases were using tampons, the controls were also using tampons, right? Then you lost your ability to pick up a difference between case and a control. So your odds of using a tampon were fairly similar among cases and controls. And that's why it ended up in biasing the odds ratio, right? And that's what they found. They found that in this particular study, friend controls were much more likely to have used tampons than neighborhood controls, right? It's still significant. It's still an association that held up. But in this case, if the true association were not this massive, you could have easily missed it if you had only used a friend control design, okay? So that's why this friend control can be sometimes dicey, because friends, cases, and controls share similar exposures, and that will bias the odds ratio. The second big problem in any case control study is what we call information bias. Remember, in a case control study, you are always historically looking back at the exposure. Unless there was fantastic records available to document exposure, you are at the mercy of interviewing cases and controls to figure out what they did or did not do in the past. And whenever you're asking questions in an interview, you really have to worry, are the cases reporting information differently than than the controls, right? We call it differential misclassification. We call it differential recall, right? So if I was a case of lung cancer and you interviewed me on my smoking history, and I already know smoking and lung cancer is associated, right? I've read it in the newspapers. Am I likely to remember better because I'm already a case and give you much more accurate information as opposed to if I didn't have lung cancer, right? That is differential recall, because cases and controls can remember events in the past differently because of the fact that they have disease or they don't have the disease. I already gave you an example last time. Moms who've just delivered a baby with congenital anomalies will tend to ruminate over what she did or did not do during her pregnancy. She will even remember in the third trimester, she drank one glass of wine, and maybe that's what resulted in this, anomaly. She is really agonized and she's thinking very hard. She's racking her brain to figure out, what did I do wrong? What happened to me? Right? While a mom who's just delivered a healthy baby probably will remember nothing on really what happened, right? Because she has no incentive to dig deep. She's happy, she has a healthy baby, she's moved on, right? She's forgotten about all the stress she may have undergone during pregnancy. That is called differential recall. Also, if I was the interviewer, I knew who was a case. I know who was a control. Could I probe people differentially based on their status? So if I'm interviewing somebody who's just been diagnosed to have lung cancer, and I ask them, all right, sir, were you ever a smoker in your life? And the patient says no. And I say, are you sure about that? Are you sure? Never smoked ever? Not even when you were in college? Not even a few cigarettes here and there? I might probe and probe and probe because I know this man has lung cancer. While I'm interviewing a control says, no, I never smoked. I move on to the next question. I'm not probing as hard among a control patient. And that results in observer bias or interviewer bias because I'm differentially probing cases and controls. So all this means that the information that you gather from cases and controls have to be identical. Same method, same test, same level of probing, ideally same level of remembering and recall. If you could assure that, then you won't have this misclassification or an information bias that we talk about, right? Take a look at this study, recall bias in exposure to mobile phones. In the early days of mobile phones, there was a lot of anxiety that mobile phones may cause brain tumors, right? There was some early indication that excessive use of mobile phones, and mobile phones in the early days were associated with some level of electromagnetic frequency radiation, right? They were huge mobile phones and they were not as good as what we have today. So in the early days, it was a very genuine concern, right? But then you're interviewing someone who had a brain tumor and you asking them, do you use a mobile phone? If so, which side do you hold it up to? The same side where the tumor is, or normally where do you hold up your phone, right? Left ear, right ear. And because people already were worried about this, people with brain tumor tended to recall mobile phone use better than people without brain tumors, right? And that's a challenge because that kind of differential information can easily exaggerate odds ratio, even if there is none, actually, right? Here is another beautiful example. And one way to deal with that situation, if at all it's possible, is that you hide the study hypothesis from cases and controls. You don't tell them the study is about mobile phones and brain tumors. You tell them we are just trying to figure out what are the risk factors for brain tumors. You do not make a big deal that this study is all about mobile phones. You bury mobile phones somewhere in your questionnaire, but you don't emphasize that as the primary issue you're studying, because then you're giving a hint to the patient that this is all about mobile phones. They may have read in the newspapers or watched on TV, and they're likely to remember differently. Okay, we could blind the patient's cases and controls to the study hypothesis. Here is another interesting case study on this study from Pakistan, a case control study of risk factors for suicide in Pakistan. So they identified 100 suicide cases, people who had committed suicide and died, and 100 live controls. Now, I want you to think about this carefully. Cases are all dead. Okay, suicide, successful suicide, they're all dead. Controls were live people. Okay, and generally they were found in the same neighborhood as the cases, right? Cases were identified through police reported suicides. Controls were neighborhood controls in the same locality where cases lived, and they found cases and controls, and they found a dramatic difference between cases and controls as far as depression and severe depression is concerned. Take a look among the 100 cases, nearly 70–80% had some level of depression. Okay, almost 80% reported moderate to severe depression if there was a case. Now you could ask me, so how did they get information from the case? The cases are all dead. Well, they interviewed the relatives, right, next of kin. Was your husband depressed before he died? Right? Was he being treated for depression before he died? Now controls, take a look. Only 3 out of 100 controls reported any kind of depression, right? Dramatic difference between cases and controls. So if you did an odds ratio for depression and suicide, the odds ratio is 208. Okay, astronomical odds ratio showing that suicides were strongly associated with being depressed. Now that may well be correct. I'm not arguing there's no link between depression and suicide. But when I see this kind of crazy odds ratio, I always worry about the bias in these studies. Turns out that this study had some spectacular biases. Okay, for example, only 3 out of controls having depression makes no sense, because if you take the population of Pakistan and you look at prevalence studies of depression in Pakistan, surely it's more than 3%, the depression rate in Pakistan, right? It doesn't matter. You already know in your country what your prevalence of expected prevalence of depression is, but you're only finding 3% depression among the controls, which means you've picked a control group with an abnormally low level of depression, right? The odds of depression in your control population is pathologically low. It's practically non-existent, which means it's quite possible, due to lack of blinding, that the quality of interviews were vastly different. If I was interviewing the next of kin of somebody who committed suicide, I may have spent a lot of time probing about their mental health and getting their depression. And the relatives who gave the information may have also over-reported depression because they just had somebody die in the house, right? Was your husband depressed? Yes, yes, yes. He was very sad before he died, right? And then you interview a live, healthy person. Are you depressed? No, I'm not. Why? Because there was already so much stigma around mental health in Pakistan or India or most countries for that matter. So if somebody asked you about your depression, you're not going to give them a straight answer, right? So controls dramatically underreported depression, while cases were excessively reporting depression. You ended up with this spectacular 208 odds ratio. I promise you, it is way lower than this. It might still be significant, but this is a one heck of a biased odds ratio because of differential information from cases and controls on depression. Okay, beautiful example of how if you don't get information correctly, you can have a massive difference. Try walking into an average household in India or Pakistan and asking people whether they're depressed. They'll all tell you that they're fine, right? You're not going to get any worthwhile information on this kind of a study, right? And so that makes this a challenging kind of the control group itself is problematic. But even if you had a good control group, your information on mental health that you get from healthy controls will be vastly different from people who've just died or who are very ill. Okay. And then lastly, we also know confounding is a massive problem in all case control studies, right? We tried to adjust for some of that in the design stage. For example, remember we had age-matched women in the tampon study. When we match a case and a control on age, we've already knocked off age as a confounder because you made sure age is comparable among your cases and controls, right? You could have age and sex match controls, so that already helps you adjust for that. We also call that restriction. You're restricting the study only to women. You're restricting the study only to elderly people. Whenever you restrict a study to a certain category, you made sure nothing is varying within that category. And that ceases to be a confounder, right? You made sure there's no variability in that particular area. So if you only take pregnant women in your study, then everybody is pregnant in the study. You restricted the study to only pregnant women. Now you made sure pregnancy is not a confounding issue, right? But invariably, every single case control study I've ever seen will do multivariable analysis to adjust for confounders. They'll say, here is the odds ratio, the crude odds ratio. Then they'll say, we then adjusted for age, sex, socioeconomic status, disease severity, a whole bunch of things as potential confounders. And here is the adjusted odds ratio, which the multivariable analysis will give you, right? So I've done case control study analysis using logistic regression, very easy to do with statistical software. So long as I have information on all the confounders of the covariates, it's pretty standard to do this kind of analysis and report that in the paper. Okay, so let me stop here.